Welcome, everybody. Dr. J, I'm not going to be able to say your name correctly, so I'm going to let you go ahead and introduce yourself if you don't mind.
Okay. Hi, Annie. So, hello, my name is Murali Janakiram, and I'm one of the physicians at the University of Minnesota who specializes in multiple myeloma. Annie asked me to give a presentation on multiple myeloma, and hence I'm happy to discuss about multiple myeloma and see what questions you have. Is there any specific areas where you want me to focus or where you want me to stop? Okay, so let me start my presentation. So medical review, the following slides were reviewed by Dr. Cole. And this program was developed by Cancer Support Community. And I am the presenter. I have no financial relationships or affiliations to disclose, and I'm not being paid by any companies for this presentation. Today's discussion is what is multiple myeloma, causes and symptoms, tests, treatment options, question and answers, and further to that is evaluations. So what is multiple myeloma? Multiple myeloma is actually is a type of blood cancer which starts in plasma cells. So plasma cells are normal immune cells which are in our body and can fight off infections. When cancer starts in these cells, it is called multiple myeloma. And these abnormal cells make a bad protein called M protein, which is what we measure in the blood. Very often people ask me, because I diagnose it with a bone marrow, whether this is bone cancer. It is not, because the marrow is the one which produces blood, and hence the plasma cells find it as home. So that is why they keep living in the bone marrow. And this is also not a skin cancer, as myeloma can be confused with melanoma, which is a different type of bad skin cancer. So I'll skip this slide and come to this later. What causes the cancer to form? And many people have the same question. Doc, what could I have done differently for this cancer not to show up? Or why did I get this? Is a very, very common question which is asked. So what I usually say is this. Over the course of our lifetime, our cells multiply, keep on dividing and produce new cells. All the information is stored in the DNA. And every time a cell multiplies, it tries to faithfully reproduce the DNA. But as we grow older, mistakes happen. And when these mistakes accumulate enough, it causes cancer. And if in case these mistakes are in the plasma cells, it causes multiple myeloma. So in most people, most of us, as we grow older, we get mistakes in our cells. Usually our own cells are very good at identifying them and either correcting them or deleting them. If they don't, unfortunately, in some people, it develops into a cancer. So in most cases, it's not quite clear what causes this. And there's relatively nothing which we can do to modify this risk. Who's at risk for multiple myeloma? So even though we don't know exactly what causes this cancer, we know that some people are at a slightly higher risk of myeloma. If you're older than age 60, African Americans, if you're related to someone with multiple myeloma, usually it will be a first degree relative. men are more likely to be diagnosed, very overweight or obese, and if people were diagnosed with other plasma cell disorders in their family, in their close relatives. So these are the known risk factors which can increase the chance that a person can get multiple myeloma. So what does this cancer do? This cancer, the problem with multiple myeloma is it quietly multiplies in the bone marrow and then secretes this bad protein. So the problems are related to these two. One is low blood counts because the marrow produces other blood cells as well. And hence if the myeloma is too much in the marrow, then it cannot produce other blood cells and hence it can cause low blood counts. It can cause decreased kidney function because this bad protein has to be excreted through the kidneys and hence it can cause decreased kidney function. Because it multiplies in the bone, it can actually destroy the bone as well, and it can lead on to bone turnover, which can lead to high levels of calcium in the blood. So all these three leads on to weakness, fatigue, and infection, and also bone pain. About 10 to 20% of people with newly diagnosed myeloma will not have any symptoms at all, and they are incidentally diagnosed because of a blood test. So the common things are physical exam and health history, general blood tests, specific myeloma blood tests, and chemistry tests used at diagnosis. People can be diagnosed with multiple myeloma in various ways. I've seen people because some people have had fractures, and when they went for an X-ray, we found lytic lesions in the bone, and that is one way. The second way is some people's kidneys are not working normally, and when they go to the nephrologist or their primary care physician, they notice that there's a bad protein in the blood, and it is also diagnosed that way. The third one is when we go for routine blood tests, sometimes the protein ratio can be altered, and that in turn triggers a workup, which in turn leads to a diagnosis of myeloma. So all these are the ways which I commonly see multiple myeloma being diagnosed in a person. So the other test, once a cancer is diagnosed, I usually ask three questions. What is the cancer? Where is the cancer? And how strong is the body to accept treatment? Okay. So the first question is, what is a cancer? So in order to establish a diagnosis of multiple myeloma, we commonly use a bone marrow biopsy to do that. Where is the cancer, or how much is the cancer in this multiple myeloma? We can usually see by a PET scan or a CAT scan and by measuring protein levels in the blood. So those are the ways in which we can say how bad or how much cancer is there in the body. And the last one is how strong is the body to accept treatment, or how do we tailor treatment to the person. For that, in multiple myeloma, because the chemotherapy drugs, when compared to other cancers, are relatively mild, we don't usually test like the heart or the lungs specifically before we start treatment. But usually it's a good idea to have a good idea of what the baseline heart function is, what the kidney function, and what the liver function is. So there are a bunch of tests which are over here, and there are only two tests which are usually important. One is the serum protein electrophoresis, which detects the presence and the level of M protein, which says how much myeloma does a person have to start off, so that we can follow what the treatment does. And the second one is usually the serum free light chains, which also says how much myeloma is there in a person, and this in turn is reflected in the blood. Of course, there are lots of nuances in this, but in general, these are the two tests which most people will follow over time to see how the responses are and say whether the myeloma is responding to treatment or not. Diagnosing myeloma. So there are two other conditions. One is called MGUS, which is monoclonal gammopathy of unknown significance. So this is a non-cancerous condition. It can be called as a precursor condition, but less than 10% actually progress to multiple myeloma from MGUS. So most people with MGUS will not get to the next stage of multiple myeloma. The other one is smoldering multiple myeloma, in which it is I would say it is a stronger precursor condition to myeloma. I would still say it is a non-cancerous condition. It is a non-cancerous condition, but it can be considered as a pre-cancer, and a significant proportion of people can progress to multiple myeloma depending on the number of risk factors they have at that point of time. Both these are diagnosed with a bone marrow biopsy and by making sure that the other organs are not affected. The last one, the other variation of this is plasmacytoma, which means that there is one specific mass in the body which is causing problems, and usually it can be treated by radiation. When we say multiple myeloma, it usually means that the cancer is in the bone marrow and it has spread to other parts of the bone and causing bone lesions, or it is causing some other problems with the organs like kidney dysfunction or rare syndromes. So diagnosing myeloma and its precursor conditions. The MGUS and the smoldering myeloma are usually diagnosed by a combination of the bone marrow and blood tests and making sure that there are no lesions in the bone. In multiple myeloma, usually we show that the cancer is in the bone marrow, and one of the following signs, which is over here, which is defined as high calcium, if the kidneys are not working well, if there's a significant anemia, or if we see lesions on the bone scans. Mm-hmm. So the next step is how bad or how good is the multiple myeloma is the next question. And this is where we risk stratify people. Basically, if you remember earlier in my presentation, I told that cancer occurs because of mistakes which a cell produces. These mistakes are called mutations, meaning there's a slight alteration in the genetic code. And what we can do is find out what mistakes or mutations a cell has, and depending on that, we can classify myeloma as standard risk or high risk. Basically, these two definitions essentially means that in standard risk, we expect treatments to give a longer periods of remission. If someone has high risk, we expect the same treatments to give shorter periods of remission. And I think in this age, this is what this essentially means. But at the end of the day, I think each person is different. And the trajectory of each person's labs and how the myeloma has responded to treatment is also very important. And these become good prognostic factors for a person. So how do we treat multiple myeloma? Until a cure is found, multiple myeloma is treated like a chronic illness. Sometimes I use an example of diabetes at high blood pressure, because once you're diagnosed with it, it nearly lives with a person for their lifetime. So multiple myeloma is also a condition like that currently. And it is more becoming like a chronic illness rather than a cancer which we can cure. But we are certainly working towards a cure, and there are clinical trials which are trying to test whether maximal therapy at smoldering stage or early stage will get us a cure. But till now, we haven't found it. And I think only a small percentage of people, approximately 3 to 5% of people, achieve really long-term remissions with the same therapy as we give for other people. We don't know why, and I think we need to understand much more in this area. But until then, we are right now treating myeloma like a chronic illness. Treatment planning. Treatment planning is based on everything. That is, first, what is the stage of multiple myeloma? What tests, what does the FISH test show? Whether it is whether the multiple myeloma is being a standard risk or a high risk. What is the age of a person? What are the goals and preferences of a person? What is the medical history and prior treatments for a person? Everything adds up in treatment planning. And that is the most important thing. That is, the treatment for two persons with 50 who are 50 years old may not be the same because of other conditions and what their goals are. Or even at 80, it's the same rule. I think the treatment should be tailored for each specific individual person and then given. So how to choose a treatment plan? I think this is very important, and it also, and pretty much in my clinic also, I nearly consider all the factors. What is the age of a person? What other conditions can impact the treatment of multiple myeloma? How bad are the symptoms? How far are they coming from? What is the risk profile? Is it a standard risk or high risk? Access. Are they able to afford the drugs, or we should not start the treatment and financially ruin a person? That's very important as well. What are the goals of treatment, and what do they want to achieve? Some people might say, look doc, whatever it is, I want to continue to work no matter what. Do the best you can, and I'm going to do this. Some people will say, give me maximal control right away, and then I will decide later what to do. So lifestyle and goals of therapy are very important. And whether there's a clinical trial available is also important to take into consideration. So these are all which really goes into choosing a treatment plan for a specific person. Overview of treatment approaches. The first two, which is MGUS and smoldering myeloma, are more, the MGUS definitely, it is a non-cancerous condition. It may be called as a pre-cancer condition, but most people with this will not progress into cancer. So we don't do anything, we just wait and watch unless we know that the myeloma protein is affecting the organs. The second one is smoldering myeloma, where I still say that observation is a standard of care, and in very selected people, after discussing treatment options, the benefits and risks, we can consider medications like Revlimid or clinical trials at that point of time. The third one is active myeloma. In active myeloma, or if we definitely prove that this is multiple myeloma, then we go through a certain steps. First is induction treatment. That is to control the myeloma and put it into remission. The second one, which is depending on the age and depending upon whether this is the right thing, stem cell transplant. This is done in order to increase the depth of response of a particular person. The third one is maintenance therapy. This is given in order to keep the person in remission as much as possible. And the last one is relapsed myeloma. Unfortunately, myeloma in most people come back, and at that time we give treatments for relapsed myeloma. The second and third very important things are bone strengtheners. Because the bones are thinned out, we will give bone strengtheners when we start treatment, and also infection prophylaxis. We make sure most of our therapies can be associated with a higher risk of shingles, and hence we also give infection prophylaxis. Treating MGUS or smoldering myeloma. It is usually we do active surveillance. We watch the proteins and see how it goes over time before we recommend that we can stop the screening or whether we need to treat. Healthy diet and exercise habits are always good. Relaxation strategies. It is, no matter what it is, visiting a cancer doctor or being followed by a cancer doctor, or even knowing that this is pre-cancer and it can turn into cancer, is stressful. I don't think anyone can be prepared for this, for either the pre-cancer diagnosis or the cancer diagnosis. So I think relaxation strategies, I know it's easier said than done, but those things can help. And talking with a professional counselor or someone who people rely on is also good. And the last one, again, it's easier said than done. Focus on what gives you pleasure now instead of worrying about the future. One of the most difficult things to do. Drug treatments. There are different types of drug treatments for myeloma, and it can, most of these drugs, even though they are classified as chemotherapy, they have, in my opinion, they have far less side effects than chemotherapy. And whenever we say chemotherapy, we think of nausea, vomiting, and hair loss. Usually these initial drugs do not cause these and are much better tolerated. And I know tolerance is different from one person to another. It's a very relative term. For some people, some side effects are more, and for some others it might be less. And then chemotherapy and steroids are also important. So these are also some of the other methods of treating multiple myeloma: stem cell transplant, bone strengtheners, I think complementary therapies like acupuncture, relaxation, and treatments to manage other symptoms. Tools of the trade. We have a lot of medications, including Revlimid, Velcade, Carfilzomib, which are the three most common drugs. Now daratumumab is also common in order to use it in the frontline setting. And then chemotherapy with Cytoxan, the steroids or the linchpin of the initial treatment, the Decadron. So we have quite a bit of tools to start off treatment. This is Gilda's club. It's live. So these are the treatment sequence and regimens for active myeloma. I know it's it's a very busy slide, but I think it's suffice to say we have enough medications at this point of time that we can actually get the myeloma into good remission in most people. So the induction, which I talked, the consolidation is the part where we try and go one step deeper into getting remission. The third one is maintenance, which is keeping the myeloma in remission as much as possible as well. Treating relapsed and refractory myeloma. Again, the treatment offers will depend upon, I know that the slide was the factors which we went through in actually deciding the initial treatment. It is nearly the same thing which goes again into every treatment change. Is this the correct regimen? Is this the most active regimen? Does the side effects, will the side effects of this regimen worsen any previous side effects or any other conditions which a person has? What are the clinical trials which are available? What are the past treatments which a person has received and how well have they worked? And based on that, can we predict this treatment? What does the fish show? So all these goes into thinking about relapsed and refractory myeloma. So drug treatments, supportive care drugs and palliative care, complementary therapies for pain reduction, and treatments to manage other symptoms. So even though we have been very successful in myeloma treatments, we still have a long way to go. And unfortunately, most people still pass away because of the myeloma itself. And hence, we have all these supportive care drugs and palliative care as well. Possible treatment options for relapsed myeloma. Again, it is a tremendous progress which we have made over the last few years in adding new drugs to treat multiple myeloma. And I think it's a great thing which is happening. Every year, I think at least 1 or 2 myeloma therapies will be approved, and that is what I think going forward. So it is not surprising we have all these drugs, including daratumumab, pomalidomide, carfilzomib, elotuzumab, ninlaro, selinexor, and other drugs, including belantamab, which has recently been approved. And for example, for relapse myeloma, that is, if a person is relapsing, at each relapse, at the first relapse, it always depends upon, as I said, what are the prior treatments and what should be the best combination at this point of time is what we think about. And then we have the second line treatments or further treatments, as I call it. And it's the same medications in different combinations, which we can do. And clinical trials are an option at any stage of multiple myeloma. We have just opened a couple of clinical trials for myeloma. And basically, because the University of Minnesota we have studied immunotherapy for a long time, that is where the focus is really on how to use immune therapies to battle out multiple myeloma. And that is where most of our clinical trials are focused as well. So as I said, bone support is very important, and we use bone strengthening drugs, vitamin D and calcium supplements to help bone healing, orthopedic supports, drugs to control pain. All these are very important. And then I cannot understate the importance of exercise as well, because the muscles attaching to the bones is what actually causes the bones to even strengthen further. The more we move, and that is how every day our normal body works. When we move or walk, our muscles pull on the bones see this as a signal, and they keep recycling themselves. So that is why exercise or movement is such a strong stimulus for the bones. And your healthcare team. The healthcare team is usually made up of an hematologist, oncologist, and the supporting team. And the last thing is always Whenever you think you need a second opinion, I think people should always go ahead and do it. I don't think any physician is upset or gets upset because of a second opinion. I always say this to my patients also. Even when we buy something, we go to 2 or 3 stores and we convince ourselves that this is the right thing to do. So it is the same when it comes to our health. If we need a second opinion, we should get it. And again, part of it is actually dictated by insurance also, and it's the same thing. There's no clear right answers when it comes to insurance. Even I struggle with it. But a second opinion can always help you confirm the diagnosis. If a physician hasn't thought about one angle, it can help to bring out something else. Palliative care services. Palliative care services provide relief from symptoms, pain, and stress. I think this is also very important. It is provided by a team of healthcare professionals who can see whether they can help you more with the pain or with the stress of cancer diagnosis. Open communication is key. I agree. Your symptoms, how you feel after every treatment, your questions, if you use any over-the-counter drugs, and what are your goals of treatment? What do you think? How things are going is also very important. Ask questions: which treatment should I start? What are the side effects? How will we monitor? What is the treatment cost? And when should I switch from one treatment to the other? The other questions are, is there a clinical trial that I should consider? Can I get a break from treatment? What should my family and friends expect? What else can I do to stay as healthy as possible? Can I suggest any dietary changes I can make? What other resources or support groups are available to me? So I have come across every single one of these questions in either these forms or in various forms. And I think all these are such important questions to ask. And they might be, you can ask it during one visit or over the course of 2 to 3 visits as well. So I think this is fine, but these are very good questions to ask. And the main thing is summary, your myeloma diagnosis, risk stage, and how to read the protein level, your care team, what side effects can you expect, where to get a second or third opinion, your past response to treatment, and what are the clinical trials available to you. These are all very important. Coping with multiple myeloma or cancer, it's one of the most difficult things. To help feel stronger and help you cope, aim to eat better, drink fluids and exercise daily, avoid infections or illness as much as possible. I think this should be said as avoid coming in close contact with people who are sick rather than saying avoid infection, because most of the infection, when it comes from our own body, and easily it can, like, our mouth, our gut, our lungs have thousands and thousands of bacteria every day, but we don't get infected. But when the immune system is weak, one of these can cause an infection. Avoid heavy lifting. Be careful with strenuous exercise. The word is strenuous. Do what you can, and you can do it more frequently. Seek help if you feel scared, depressed, or anxious. This is a really difficult diagnosis to cope, and it is tough for any person. And take advantage of cancer support resources to help you and the people who care for you. Conclusions: there are no known ways to prevent MGUS or multiple myeloma. the goal of treatment is to live for as long as possible with the best quality of life, keeping your goals in mind. It is best to work with an experienced team. Be open and honest when you talk with your nurse and doctor, and similarly, they should also be. It is a very no, I wouldn't say exciting, but it's a very good time because there are new drugs which are being added, which can help us treat myeloma more effectively every year. So this is a great age of science where we have all the scientific tools to discover new drugs and work towards a cure as well. And people can learn to cope with this diagnosis for a long time by being empowered to gain control, knowledge, and support.